Welcome to The Expert Approach, a podcast from Urology Times. I'm your host, Joy Maulik, a urology nurse practitioner, and together we will explore the evolving role of advanced practice providers in urology and in uro-oncology. Each episode, we will sit down with the thought leaders, the innovators, and the real-life experts who are shaping the future of care. Our goal is to bring you real conversations that inspire, inform, and empower the whole community in urology. Today, in the first episode, I am excited to welcome John Brandon Arruda to the Expert Approach. Brandon is a urology oncology nurse practitioner with WVU Medicine, where he treats patients with urologic needs. Now, he has many hats, so I'm going to go slow on these, okay? Beyond his clinical expertise, he serves as the program director for the WVU Urology Advanced Practice Fellowship and is also the senior APP for the surgical service line with the Office of Advanced Practice. I'm taking a pause so that I don't miss anything. He's deeply involved in shaping the future of APPs, and this is what separates him. He is an editor for the Society of Urologic Nurses and Associates Journal, an adjunct professor for WVU School of Nursing and Physician Assistants, and he's also a guest lecturer in conferences along with national meetings like American Urologic Association. He is also creating an educational opportunities nationwide for APPs and chairs the AUA's Life Education Subcommittee and plays a key role in making sure that the role of APPs is recognized. So after what I went through, it must be clear that he is not just practicing urology. He's shaping the future of it. Brandon, welcome to the Expert Approach.
Wow. Well, thank you, Joy. The introduction is more than I expected, and sitting here listening to it, I'm beginning to question how many hours of sleep I'm actually getting at night. Growing up, right, we listen to people when we're young in our career and they start going on about their resumes and things that they've done in their career. And you're like, wow, how does that person have time for anything? And then sitting here listening to you, I'm like, oh no, I've become that person. And that's wild. And I appreciate such a great introduction. And it's an honor to be here as your guest and as an advanced practice to really just kind of translate years of doing this role into what it means for urologic APPs now and for the future.
No, I appreciate you coming, especially on the first one, and being so kind to give your time. That was my question. When I was looking at your resume, man, you're busy. But I'm going to start with a totally different question today.
Yeah.
My question is, John or Brandon? Why Brandon and not John?
Okay, that happens a lot. So, legally, everything is your full name, John Brandon Arruda. And when patients check in, they're like, I'm here to see Brandon. I'm here to see John. And the receptionist or the check-in staff like, oh, you're seeing Brandon. And so it's always, every 15 minutes for 30 patients a day, it's, oh, hi, I'm John Arruda, but I go by Brandon. And the story is it's a simple one, right? My dad's name was John Frederick Arruda. I'm John Brandon Arruda. And so we needed a way of distinguishing the both of us over the years. And so I'm Brandon and he's John. So, nothing too extreme there, but it's definitely something that I as a John Brandon deal with every single day, every 15 to 30 minutes.
No, I hear that, man. That's good. I love that. But it's
Yeah.
better than a man with a female named Joy. I can tell you that.
Well, that's a great question. That's a great comeback. How are you managing that unique nomenclature for yourself? Because I'm sure it's a very interesting conversation when they see a name and you walk in.
Yes, I disappoint patients every day. They're like, oh, yeah. So, boom. But as you can tell, I have my Indian background. So,
Yeah.
so Joy actually means victory.
Yes.
It's more of a masculine name than what it is.
Yes.
But talking about names and talking about urology, let me ask you this. You have been in this space for a while.
Yep.
So my question is, what led you to urology? But more importantly, what I'm really, really intrigued to ask you is, what makes you stay in this space?
Oh man. So that's a cool story. Been a nurse practitioner for over a decade. Been with WVU Medicine for almost 2 decades.
Oh, wow.
But urology was an accident. When I graduated from my nurse practitioner program, like most new graduates, what do? We shotgun out our applications. Unless you're already kind of settled and niched in a profession that you already are passionate about, you really don't necessarily know where you're going to land. And I'm exactly that living proof. I had no idea what I wanted to do. My nursing background is in psychiatric mental health and level 1 emergency medicine. And I was done with both of those career fields and really wanted something new. So I 12 gauged it out there, just shot it out there and saw what stuck. And urology was one of those that I never expected to go into. But the culture and the staff were so welcoming and ready to teach. And urology as a practice really embraced early on the value of advanced practice providers. And so that's what got me in the door. What has kept me for the last decade plus is the continued support of urologists locally at our state and nationally for not only my practice and our department's practice, but for advanced practice in the urologic space, as well as a drive to be able to give back to a specialty that has cultivated and allowed me to fulfill my itch and that need to work at my top of license, top of practice. Because as you know, there are professions and practices out there where advanced practices are very limited, either by state licensure regulations or by local hospital requirements in what they can and cannot do. And I'm blessed that our organization has given us the opportunity to really function at our top of license scope. And at least, that has kept me engaged and fulfilled from a career perspective. But on that, note, I feel that from a subspecialty perspective, the urologic space is continuing to evolve in our need for advanced practice integration into the deep interstitium of diagnosis and care of patients as we begin to see the unfortunate decline in our urologic providers going into the profession or retiring out of the profession. That gap has really begun to widen, as I'm sure we're going to talk about moving forward. But yeah, what's kept me here? Dude, I worked for one of the coolest organizations in this country. I'm sorry. WVU Medicine rocks. And I've been pumped to be here from almost 15 years plus at this point.
That's great, because when you were talking about it, I can see that how, I sometimes body language speaks when
Oh
we're
yeah,
happy.
yeah.
The few things that you said, you used the word drive. And that's funny because one of my favorite books about leadership is Drive by Daniel Pink. And Daniel Pink talks about, you know, autonomy, mastery, and purpose.
Yes.
And when you speak about your culture, the inclusiveness, it seems like they're all there for not only you, but for the whole team to kind of cultivate a positive culture. That is great to hear.
Hmm. It's we have a really good thing going. We really
Yeah.
do.
So now we're going to talk about a lot of deep stuff. But before that, without any humor in urology, that just sucks, right? So
It makes it pretty bad. Yeah.
let me try a joke. I'm not good at it, but I'm going to try it.
Well, this will be good.
So how does a urologist diagnose hypospadias on an EKG?
How does a urologist diagnose hypospadias on an EKG? I've heard a lot of urology jokes in my career, but one I have never heard. So I'm ready. How does a urologist diagnose hypospadias on an EKG?
By spotting the inverted P wave.
No, you didn't. I'm stealing that one. That one's now mine.
That's great, man. Because sometimes like you say, you hear a lot of jokes, but that one has been kind of with me for a long time.
That's good. That's that's good.
So let's deep dive now because you have a clinical role, you have a administrative role. So let's talk about the fellowship program that you guys have right now, and how did that evolve? How you got in, and what are the future steps that you're looking?
Sure. So, you know, I should have mentioned this kind of before, but as I sit here, everything that we're talking about is kind of my personal takes on things, my personal opinions. They're not going to reflect WVU Medicine's positions or statements, but just that disclaimer out of the road, the idea of fellowships and the idea of training advanced practice in the role in science of urology was born out of a need for more providers in the state. West Virginia, unfortunately, ranks fairly low in super desirable locations to live and work. Well, be it because we're not a super rich state, or we don't have the cool Niagara Falls or Yosemite to look at. What we do have is beautiful mountains and forests galore, but that doesn't seem to attract many providers to this area. And so what we have noticed is that our workforce is aging and our workforce is retiring, and we're struggling to bring in urologists to the state and then really into the surrounding states that border us. And so back in 2022, the idea was born after a urologic conference in our state of, well, how do we elevate the role of advanced practice to bridge this gap that we're noticing in the urologic specialty of the state? And so that really bore the conversation of, well, we just can't take them and just drop them into practice because they'll drown. We need a formalized educational process. And so, that immediately set off bells in my head of, we need a fellowship program.
Yeah.
And, having never done something like this before, the amount of learning was intense because West Virginia does not have any other fellowship programs in urology. So there was nothing that I could build this off of. There's one fellowship program in the entire state for advanced practice, and that is in primary care at the very bottom of our state. Right. So that wasn't even something to build off of to begin with. And so the national hunt to gather data began. And we have great programs across our country from Mayo Clinic to Stanford to Duke and Atrium that have built urologic fellowship programs for APPs, and I use that as a broad sense, meaning our nurse practitioners and our physician assistants / associates, that through beg, borrowing, and conference calling, I was able to kind of use their foundational framework to develop our internal programming. And it really bore fruit through development phase through 2023. But as with everything, Joy, you and I both know that money is king, right? Yeah. Money is king. Things don't happen without the dollars. Yeah. And to that end, navigating still a COVID-dense environment where we're still recovering from the pandemic, seeking money to develop a new program that's not been done before was challenging. But we were able to really translate the value that the program was going to generate for us into a language that financially made sense. And it culminated in the launch of our pilot program in 2024, which just finished up in August of 2025. So we had one fellow that we took as a trial from our endemic program here at our physician assistant school through WVU. We put her through an intensive 12-month rotation through 6 months of general urology, 3 months of pediatrics, and 3 months of urologic oncology. All of that was combined with didactical education through self-learning tools. Unfortunately, she got to look at 37 videos I created with my head just walking through PowerPoints. So I feel really, really bad for her on that one. But the idea was to combine didactical work that they could complete independently on their own time with real-world case workload to simulate what it's going to be like in clinical practice, with the ultimate goal to train and retain. That's my fun statement. We're training to retain our providers in the state. Because ultimately, while we will eventually saturate and be able to feed the nation with urologic trained, fellowship trained APPs, right now we need desperately to, hold tight and keep our people in West Virginia. Thankfully, we were successful, right? So we graduated her. She came on with us and is flourishing in her role. And so what the program taught us was that in certain subspecialties that are lacking formalized education through your initial training, there is room for implementation of fellowship training, that it can be done financially savvy in ways that are giving you an ROI without a significant deficit from a financial perspective. And really, what do you get out of it? You get out of it a provider that can really hit the ground day one post-fellowship, functioning as a fully fledged provider with deeper knowledge than what they did, a year ago. Because we all know, you and I did not go formalized fellowship programming. How long does it take to get you up and running, Joy? About a year, right? About a year. And what are you doing for that year? You're doing everything that you would do in a fellowship without the formalized data points or, formalized process of training. And so we were able to develop that in such a way that we tracked every metric. We tracked how many new patients, how many return patients, procedures. The fellow did more cystoscopies in her training than I did in the first year.
Wow.
Right? So
I'm going to dive into that procedure in a minute.
Sure.
That's music to my ears.
Yeah.
Yeah.
So ultimately, it was a great thing. Absolutely fantastic. And it's broadened the discussion of fellowship programs through our organization as a whole. So I think great things for APPs to come.
No, I love that because, onboarding somebody new coming in, it's almost like when you explain it, it seems like the expectation was more on the organization than the candidate coming in. And it's kind of like a built-in mentorship. And I say this in a way because, as you and I both know, that about 24% of the healthcare workforce is APPs, whether it's nurse practitioner, physician assistants, nurse midwife, nurse anesthetist.
Yes.
And burnout is real. And sometimes the burnout can come in many forms, especially if you're new in a subspecialized space, you don't know, you're not confident. Having that somebody that is there to kind of shape you through that's beautiful. I mean, it's really, really good and encouraging for future APPs. Like you mentioned, we did not have that luxury, but at least we know that the future generations will have that.
Yes.
So that sounds like a success story, man.
We're really proud of it. As a department, as somebody who is passionate about the program and the education, it has been a personal professional success, something that I look forward to growing and expanding as we as an organization continue to make plans and step into the future of advancing our profession as a whole.
Right. So you touched on the procedure. I'm going to get into that now, but just so you know, I love West Virginia. I have lived in Beckley, West Virginia for a little while.
Okay.
And I love the Appalachian trails.
Oh, yes. Oh my gosh, you can get lost on that thing if you ain't careful.
And just full disclosure, I was a Marshalls fan because of Randy Moss.
Joy Maulik, buddy.
So let me. No, but I had to say that, which I mean. But let me ask you this: like, you do procedures. Let's start with what procedures are you doing now? Because a lot of organizations still are not utilizing APPs to complement the urologic surgeons in that role. So let's talk about it.
Sure. So, in full transparency, our procedures were born again out of a need for more all hands on deck.
Right.
We needed too many patients, not enough providers. And so that bore the fruit for us as a department and as a team to develop the protocols, procedures to enable APPs to gain the training and the expertise over time to do procedures. And it's funny because we are beginning to have the conversation on the latest and greatest in bladder cancer care. I'm sure you've read the reports of the TAR 200 that just got approved, right? And I'm having a conversation actually just this morning about, hey, we need you to get trained because you need to do these because they're cysto intense. And so, what a cool feeling, right? To be able to say that, we're going to get to do these things. But back to your question, what do I do? I am trained and certified to do my own cystoscopies with stent pools. I do my own surveillance scopes, initial diagnostics for new hematuria workups.
Wow.
I do complicated Foley insertions, guide wires. I do BCG installations. I do injectables for Trimix for our ED patients. Gelmito, a brand name medication, and Elixol installation of chemotherapies. I do that procedure independently. As of right now, that's enough.
Of course, because see that the key thing that you just brought in urology space, in the GU cancer space, so many new innovations are coming.
Oh my gosh, yes.
And what good are the innovations if you don't have people that can execute it?
Right.
And that brings me to another point that I really, really admire the urologist in your group that is taking the ownership to train the team so that your patients and your community are the big winners at the end of the day.
Again, I have to give all the credit to the faculty physicians that really recognize the benefit that we bring as part of the care team and the delivery model. They know what we can do, and it is that collaborative trust back and forth that has enabled us to really enhance the offerings that we have in our, not in our office procedures, but as a care coordination team.
Yeah.
We really are making strides to streamline processes so that patients can benefit ultimately from a more seamless hospital experience. Because as you know, when you walk into an academic institution, you're going to spend 20 minutes just trying to find registration.
That is so true. That is so true. So you brought this bladder cancer, so I cannot just exclude that and tell you what an awesome spot-on presentation you made at AUA. I mean, I personally learned a lot, and I really enjoyed the delivery that you gave. That was for APP sitting in the audience. It gave me hope that, okay, I think I can do that.
You can do that. I'm 100% sure you can do that.
So that brings us that touchy subject of hematuria, because you essentially are, when the new patient coming in, you're evaluating, you are doing the diagnostics, and you are kind of with that patient throughout that journey, whatever is needed, except if they need cystectomy or something, I would think, then, and then you just take that to the follow-up.
Yeah.
So tell me, in hematuria, especially microhematuria, which I always feel is kind of like that gray area.
Yeah.
And the guidelines keeps changing, and we have the new guidelines.
Right.
To tell me your thoughts about hematuria, how, as an expert in this space, how do you deep dive into it?
Oh boy. Well, so I'll quantify and clarify the word expert is expert with a star behind it, saying that, as we learn every single day, I'm becoming more and more of a advanced novice in the world, right? So hematuria, as we all know, is you've heard of the mystery of the abdomen, right? I have abdominal pain.
Yes.
Okay, there's so many things that could be abdominal pain. It's the mystery belly. Hematuria is the same way. There are a plethora of potential etiologies of hematuria that the patient walks into your clinic and sits down and goes, well, the doctor sent me because I have blood in my urine. Well, great. What do you mean? And then you look back and you have to understand a dipstick is not, in my opinion, utilized the way it should be. That is an initial test that is then confirmed by your microscopic UA.
Yeah.
We know that microscopic UAs with 3 red blood cells or more should be evaluated for microscopic hematuria etiologies, but then we have to risk stratify them based on the current 2024 risk stratification that go low, intermediate, or high risk disease. And quite frankly, I look them up every time.
Yeah.
Every time. I have a little smart phrase that I cheat sheet and drop into a note that pulls the guidelines, because they are very nuanced based on age, less than 50, years of smoking, less than 10-pack year history, and then really symptomatic versus asymptomatic.
Yeah.
The way I approach my hematuria patients, microscopic hematuria specifically, really involves a deep understanding of their previous history leading up to their visit, because that's going to give you way more detail than most people recognize. Oh, I forgot to mention that I've been having flank pain for a week prior. It went away. but then I've got this microscopic hematuria on the little litmus paper that they dipped in the clinic, right?
Right.
My brain goes, okay, you're probably passing a kidney stone.
Right.
Oh, I've been burning for 3 days. Oh my gosh, you're probably having a UTI, right? So these are the things that cross my brain as I'm thinking about these. But ultimately, if the non-malignancy workup that we do standard, meaning, CT scan, I just default, honestly, Joy, I'll tell you right now, I default to a CT IVP, a CT urography.
Okay.
I default to it.
Yeah.
Because ultimately it's going to give me my stone protocol. It gives me my enhanced phase and it gives me my excretory phase. So I default to it.
Sure.
If all of that workup tells me nothing, a cystoscopy is a quick, relatively painless 90-second procedure that, with direct visualization, to me, gives that patient that sigh of relief that they're not dealing with a potential malignancy, which we know is incredibly low in a microscopic hematuria setting, but it's not zero. Yeah. And I the more and more I progress in this career path, the more and more I feel that patient comfort and that patient satisfaction means more to me than anything, that I could do otherwise. Because if I can give them that sense of peace with a 90-second cystoscopy in the clinic, and that's going to put them at ease and they're not going to worry about it anymore, then that's what I feel that they need for a successful journey through this, ordeal. Gross hematuria, unfortunately, as you know, is completely different. Completely different. I mean, there's no algorithmic risk stratification. You don't pass go and you don't collect $200. It's a CT ecopathy and a cystoscopy, and I do those as well. But where my practice ends, and I team up with one of my urologic surgeons, is in diagnostic cystoscopies where I find an erythematous patch or a bladder tumor. Well, I document those excessively well I can take pictures and plop them right in a chart and give a descriptor of where it's located. And the team is able to just, go right in and do their thing. So it's a really nice symbiotic relationship.
No, it's what I really hope our audience gathered. You eloquently summarized how you take patient history, how you work through your differentials, and ultimately made sure there is no malignancy, whether it's the bladder or the renal, in that aspect. That is excellent. Now, just as a curiosity, do you guys still use cytology, or are you just kind of
the $1 million question, right?
Right.
So my personal practice, I will still do a urine cytology for my gross hematuria patients.
Okay.
I don't. I do bladder washings at every cystoscopy, which is still my routine. So if I'm, we're human and fallible. So if I miss grabbing a cytology when I see them in the clinical setting, when I scope them, I'll grab a bladder wash at that time for cellular look through.
Right. And I just want to bring up one point. You brought a very good point about BCG utilization in bladder cancer and how we can do, if you can summarize in a few ways that we should keep our eyes open and mind open, not to just get stuck in the thing. What other things that we can do for these initial diagnosis of bladder cancer besides just thinking at BCG alone?
So now that we have our diagnosis of bladder cancer and the patient comes back and their head is spinning, it's our job to be able to sit there and walk them through, what does the approach to your care look like from a non-muscle invasive bladder cancer? Because just to clarify, we get a diagnosis of muscle invasive bladder cancer. Well, that's hard stop. You need a surgeon consultation. You need a medical oncology consultation. That's where we're getting into the big, deep weeds of, big time therapy. But thankfully, our non-muscle invasive bladder cancer patients, when they're categorized to low, intermediate, or high-risk disease, it's kind of like an all-you-can-eat buffet. You've got lots of choices, and we have to pick which flavor of ice cream we're going to have today.
Yeah.
Low-risk bladder cancer, typically, if it's their initial diagnosis, I love to follow them. I'd love to say, let's take a quick look in 3 months. Let's see what things look like, especially for your TA low-grade disease. Tumors less than 3 centimeters in size, solitary tumor, not multifocal, no CIS. Great candidate to follow. Take a look at them. You get somebody in your intermediate risk disease, they've got, a low risk bladder cancer that's recurred within 1 year. They've got a TA high grade, 3 centimeters in size, or they've had recurrence within, 6 to 12 months. Well, our intravesical options continue to evolve. We have mitomycin C, we have gemcitabine and docetaxel intravesical therapy. And if I'm not mistaken, there was recently Urogen came out with a newer gel mito bladder installation, and I'm blanking on the name at this point. That's how new it is. That is coming into the intermediate risk field, thereby opening up a newer option for patients. And then in our high risk bladder cancer care, we know that's anybody with CIS, large multifocal tumors, T1, high-grade disease. I love my BCG, right? BCG was the first immunotherapy that I really gained exposure to in urology, and that was even before pembrolizumab came onto the market.
Right.
But we know that unfortunately no one wants to make it anymore. Joy, you and I should get a shed out back. We'll cook this up. We'll make money. It's hard to find right now. It's not easily obtainable. So thankfully, we have these alternatives in our nefaragene viral vector agents, our pembrolizumab that we can give. And now, thankfully, with the TAR-200 now being labeled under a name that I have literally can't remember at the time, but it's the pretzel. So
right.
We are really expanding our options for patients, and the goal is that when you have that initial diagnosis conversation, you're sitting down with them and you're not going, okay, Jim, this is what I want you to do. It's, Jim, this is what you have. You're stratified as this. Let's walk through the multiple options and really paint a picture for you of what to expect, how often you're going to have to need it, and where you go to get that. Because in my region, we have patients who will literally travel 3 hours one way to the office.
Mine too.
Exactly. Right?
Yeah.
And so, unfortunately, you do the same thing I do, I'm sure, is that you take that into consideration when you're planning the treatment algorithm that they're going to follow, because you have to recognize how compliant they're going to be able to be, right? Is based on a 6-hour round trip with a 2-hour treatment window. That's an 8-hour a day for them. And you may be doing that weekly for 6 weeks.
Yeah.
Right? It is terribly burdensome to a patient and their loved ones. And while I hate that it impacts them, the realization is that it does.
Yeah. No, it does. So quickly on that muscle invasive cancer, the high risk that are not like a surgical candidate, have you guys utilized Keytruda or anything like that? And
so you're asking specifically for muscle invasive bladder cancer?
Yes.
So muscle invasive bladder cancer, whom are not cystectomy candidates either because they're unwilling to accept it or they're unfit for surgery. They typically end up with radiation bladder sparing, so radiation therapy. We call it trimodal therapy. So it's a maximal transurethral bladder resection to get all of that out of the bladder that you can, kind of clean it out, and then utilizing bladder radiation and chemotherapy for bladder cancer treatment.
Okay. Well, that's good because, and the pretzel that you mentioned is like really fresh off the press, really.
FDA,
Like literally.
Yep. Yeah, like
Yes.
so like 2 days.
Literally.
Yeah. But
Okay.
I'm excited. This is something that keeps me interested and keeps me engaged in the space because there's such a rapid evolution of cancer treatment modalities available for patients that ultimately our end goal is to spare bladders. Like, I like my bladder. It may not like me with all the coffee. I like my bladder. And so we want to keep people with their bladders as long as we can.
No, this is great, and because this is so much information for me that is helping me, and I'm sure our audience will like it. No, seriously, great presentation on that bladder cancer because it is evolving, and I just think these new innovations will redefine standardization of bladder cancer at some point.
I would not
All
be. I wouldn't be surprised if the guidelines again update in the next few years.
Sure. So keeping your time in mind, I would like for you to kind of put on your views about, besides the bedside and the clinical aspects, um, thinking about APPs is as a strategic part of leadership in any organization. What do you think? What are your thoughts?
Ooh, many, many. So I've had the distinct pleasure of being a part of some of the strategic outlines for WVU over the last few years in how APPs are seen, heard, and felt. And I can tell you that as a workforce, nationally, our numbers continue to rapidly grow and expand. And I feel that has really engaged us in a way that we are able to then collaborate at a system hospital level, especially in our larger organizations, for more leverage at the table is not the right use of the word, but ability to sit in and be a part of the conversation as it relates to strategic deployment. As we have noticed across the country, more and more organizations, large organizations, ours included, are beginning to seek advanced practice into system leadership roles.
Right.
And that speaks volumes for APPs as a whole, as a workforce profession, but also for the organizations that are taking a forward-thinking, progressive approach to the next 10-year strategic mission and how they see advanced practice being a part of that delivery care model. As you know, the discussion of value-based care in healthcare continues to be a hot button topic. And as many organizations try to determine how they're going to implement that into their care delivery model, I seriously feel that APPs are the secret sauce that will be leading that charge to an extent as it plays out in certain disease-specific areas. Urology being a prime example. You think about it as a healthcare organization, if you can deploy advanced practice leaders to oversee disease-specific clinical pathways and clinical guidelines to journey your patients through, say, an advanced prostate care clinic, right? Joy, I'm picking on you there. You're there, prostate cancer, right?
Right.
What do you gain by that? You gain an expert leader at the clinical level, at the department level, that is generating an extreme value for the organization by navigating a panel of patients through a complete disease paradigm from start to finish while freeing up our physician colleagues for that more advanced, nuanced work that is required either in the OR or that advanced diagnostic conversation when it comes to your muscle invasive bladder cancer with multiple notes that needs that deep one-on-one conversation. So from a urologic perspective, I see APPs really thriving in the world of running disease-specific care clinics, as well as advancing our diagnostic procedural-based skills. And you had mentioned my work on the live education committee. The AUA has taken a deep look at how they want to engage advanced practice in this workforce as it relates to procedures. And so the AUA is planning on, building curriculum and workshops to help APPs become familiar with cystoscopies and stents and, biopsies, et cetera, down the road, so that they can encourage the advanced practice provider to become diagnostically proficient and procedurally trained, because ultimately that leader, that APP leader in that space is going to be able to diagnose, treat, manage that patient well, while still holding that deep collaboration with our physician leaders, right?
Yeah. I agree. See, that's great, because I agree with you. I think there would be more subspecializations in urology that we would be able to do general and that. And you used the word sauce, and I agree with you, because I believe, this is just me, that I believe APPs are the salt. So if you put it in a salt, you don't see the salt, but without the salt, the dish is not really tasty. So the point is, you just need to know how much salt to put, and that's where the utilization comes in.
Right.
In a bigger analogy,
Right. And I mean, that it's a great point, right? And so that is where I think, as these large health systems are beginning to understand the value add that advanced practice brings in all of our subspecialties and all of our departments, I think that's where they're beginning to strategically place advanced practice leaders in positions that will be able to navigate how to deploy those resources and sprinkle the salt where the salt needs to go.
Great analogy, man. Great analogy.
So
Okay, so this conversation can go for hours, but I think if you have time, we would do another one at some point. But now this is our first one, just from the snapshot from your hip. What critiques do you have, how we can make this show better?
Better. So I will pivot away from better, and I'll give you my opinions on how the show should progress. I think that what this podcast means to deliver is exceptional. Having urology providers, advanced practice, having top talent that works in the urologic space is essential for us to stay on top of our game, to be advised of the latest and greatest. And I think the one piece of advice that I could give you as you develop this through season 1 through season 5 is keep it light. Keep it calm, keep it relaxed. I feel that when we in healthcare spend so much of our time stress dealing with sick individuals or having difficult conversations, the idea of being able to spread our knowledge and education and talk about things that we're passionate about in a relaxed atmosphere, at least for me, does two things. It allows me to decompress while still having a professional conversation. But it also lets me in this last hour reflect on why I'm here with you today, but also why I'm here in this field for as long as I am. And so I think ensuring that your podcast remains casual and fun, like this one has been today, I think is really going to take you far.
Oh, thanks, Brandon. That's good because I love those insights and the honesty in it because I really want this to be our podcast.
Yeah.
And so as we approach towards the end, thank you, Brandon.
Thank you, Joy. It was a pleasure.
Thank you for joining me. Thank you for your insights. Thank you for the conversation and being so candid.
Absolutely.
I really hope that you have some time to sleep with all the hats that you're wearing, man.
I will.
So, to our audience, as we come to the conclusion of this, I hope that you walk away inspired. Thanks for joining us on the Expert Approach, powered by Urology Times, which definitely adds some credibility. This isn't just our podcast. As I was mentioning, it's your space too, a place where APPs, physicians, and the entire urology community come together to share stories, spark ideas, and move our field forward in a proactive fashion. So if today's conversation sparked something for you, subscribe, stay with us, because voice of yours, your work, and your passion are what this community is looking for to make it stronger. Now, for the next time, we are going to be raising the bar again. Another powerhouse guest, another conversation that will challenge the way you think about APPs and urology. Good night.